poll now.
Just to let everyone know that I have started recording.
As I said previously, if this is the time you want to change your name or turn your camera off, do feel free. But we're going to record the event. We're going to put the poll on now, and it shouldn't take very long, but we're going to leave it open for 7 or 8 minutes so that everyone coming in can have a go at it. So the answers are true, false, or don't know. Can I encourage you, don't guess. If you don't know the answer, please put don't know. And if it's anonymous, and then you can just scroll down through the 8 questions. Take your time, and at the end, we'll close the poll just a couple of minutes before the start, and you'll be able to see what the collated answers are. Ready, steady, go. So welcome to those just joining us now. If you would like to participate in the pre-course quiz, we'd encourage you to do that. Nice way to test your knowledge of the subject. It's all anonymous. You won't be found out, I promise, but it'll give you an idea of where your knowledge gaps perhaps want to be filled tonight. And we'll cover a lot of this in the course. And then we'll do the same poll at 8:15. Just as we're finishing the formal Q&A. So you'll get a chance to change those don't knows into something else, we hope. There's 8 questions, just scroll through them. And if you're unsure, do use the don't know button, because that's helpful in itself, just to know how many are confident of the answer and how many are not. So welcome to the new names joining us. We'll be starting officially at 7, and we're just doing the quiz at the moment, so please do take part. So we're getting a spread of answers, and this is very common. And quite a few don't know. So from an education point of view, that's nice for us, because that's good that we have the goal of filling that gap tonight. We even have some divergence between the true and false as well. So as I said to those of you who are here at the beginning, we'll do the poll again at 8:15. Same questions, but that's after our 2 speakers and our Q&A. So hopefully you'll have had the chance to clear these answers in your own mind. So welcome to those just joining us. This is where the slow trickle gets a little faster. We're just doing a pre-course quiz at the moment, and we're going to leave it open for another couple of minutes. So please come and join the pre-course quiz. It's anonymous. You can answer true, false, don't know, and that will give you a chance to see where your own gaps are in knowledge and understanding, and we'll hopefully help sort those during the course tonight. So for those of you just joining now, we're just spending the last minute on a quick pre-course quiz, just to allow you to test your own knowledge. 8 questions, true, false, don't know. Don't need to guess, just put don't know if you really don't know, and we'll address those during the evening. So we've just got the last minute to do them. So please have a go in the time that we've got left to do that. And warm welcome to all of you joining us. So we'll just give it the last half minute or so. If you've just joined us, feel free to have a go at the pre-course quiz. 8 quick questions, true, false, don't know, and we'll just be ready to close the quiz down in just a minute.
Shall I close the quiz, Arlene?
That would be super, Gordana. Yes, that would be great.
And I will share the results now with everyone.
Yeah. So welcome everybody to the course. Some of you have just joined us. We've just done a pre-course quiz, and here are the collated results for what you were thinking as answers to the questions. And we will repeat this at 8:15, so you'll get a chance to do it again. So again, you can scroll through that and just see what answers your colleagues and other folks on the session tonight were thinking. So quite a high number of don't knows, and that's good from an educational point of view, that we know where we're going, and we'll hopefully be able to fill in some of the blanks for you tonight. Okay, so thank you very much everyone for taking part in that. And on that note,
shall I stop sharing the results?
Stop sharing the results. Thank you very much, Gordana. And we'll just make a formal start to our course once.
Can I just say something, Arlene, just before we start? Just to tell people that people have been texting me in the chat box directly for certificates. Tina is looking after the certificates tonight, the CPD recognition in Ireland. So please send your messages to Tina if you can, because she will be preparing the certificates. Thank you.
Thank you. Thank you, Gordana. So a warm welcome to everyone. We've done a lot of the housekeeping before the course has started, so we can make the most of this hour together. So we really appreciate you giving up your Wednesday evening to come to the first of our 3 educational events on Lyme disease, the new great imitator. I'm Arlene Brealey. I'm a pharmacist by background who's worked in community and hospital and academia, and I now volunteer for the Lyme Resource Centre as a trustee. Why? Well, my son was bitten by a tick on the Duke of Edinburgh expedition back in his teens, but it was undiagnosed and untreated at the time, and he became quite seriously unwell at the age of 18, and his life was essentially on hold for many years. And he's not alone, sadly, hence our desire at Lyme Resource Centre to really help others avoid that situation. And for you and I, as health professionals, to be fully informed about how to recognise and respond quickly to infected tick bites and Lyme disease, and to help people avoid serious illness as best we can. I wonder what prompted you to apply for the course tonight. I'm thinking maybe you're a nurse who's been asked to remove a tick correctly by a patient, and you've maybe wondered, what follow-up advice should I be giving to that patient? Or maybe you're a community pharmacist who's been presented with a rash that could have been ringworm, or it might have been cellulitis, or is it an EM rash from a tick bite? How would you know? Or perhaps you're a GP who's been presented with a really unwell patient who really hasn't got a rash, but they've had a tick bite. Or maybe they've had antibiotics and they're still really unwell. Well, whatever the situation, what's brought you here tonight, we've planned this series of webinars with speakers who've got extensive experience of Lyme disease and tick-borne illness, and we're looking forward to doing this session with you. On that note, I would like to introduce you to our course director, Professor Jack Lambert. He's a consultant infectious disease at the Mater Hospital in University College Dublin, and he's the lead trustee of Lyme Resource Centre. Professor Lambert's presented widely on Lyme and co-infections in the last few years at EU and USA conferences, and very much a voice of intelligence in the world of Lyme disease. So, Professor Lambert, would you like to just give us a word of introduction?
So hi, I was told I only have 1 minute, so I'm going to try to stick to that. So I'm an infectious disease doctor. I take care of all infections from COVID to tuberculosis and Lyme disease, one of those. And the thing that I've realized in my study of Lyme disease, and all of these studies are on our Lyme Resource Centre. I mean, if you read the textbooks, it says Lyme disease is easy to diagnose, is easy to treat. 100% of most people get over the infection. But it's not that simple. Not everybody's easily diagnosed, or the treatment doesn't always work. But I think, so I take care of the more complicated patients as a consultant specialist. And I don't, but the way to keep the numbers of Lyme disease cases down is for the people on the front line, whether it be a pharmacist or a GP, to have a better understanding of just how common these infections are. In America, they used to say 30,000 cases a year. And then all of a sudden, one of the congresswomen gets sick with a tick-borne infection and eventually died. They then established the Kay Hayden emergency fund for tick-borne infections. That was back right before COVID. And they gave 10 million to each of the states in America. And all of a sudden now in America, they're keeping track of the number of cases of Lyme disease, actually. And they say there's almost 500,000 cases. So it's gone from 30,000 where there was no monitoring now to 500,000 cases. So I think there's more cases of Lyme disease than has been recognized, has been recorded. And I think, but the best way to keep Lyme disease cases down is to catch it early through early recognition. So I think that's what the session is about today. And I'll be talking more in the subsequent sections on those where the early diagnosis is missed. So thank you for being here, and I look forward to being a part of the question and answer session at the end. Thank you.
Thank you, Professor Lambert. So as he said, he's going to be doing 2 sessions in the next 2 webinars, but he will be here for the Q&A tonight as well. So it gives me great pleasure to introduce our first speaker for tonight. Dr. Anne Cruikshank is a GP in Oxfordshire, and Anne has been the RCGP Clinical Champion for Lyme Disease 2018-19. Anne developed an interest in Lyme disease after a close family member was hospitalised with Lyme carditis back in 2007. And she has experience of managing patients with Lyme disease, both within primary care, but also within a consultant-led Lyme disease clinic. So in 2018, the RCGP approached Anne to be the clinical champion for Lyme disease and tasked her with leading the Lyme disease spotlight project to raise awareness inside primary care. So Anne's the ideal speaker to open our series of webinars tonight on Lyme disease, the great new imitator. Anne, over to you.
Just one thing before Anne starts, so I don't interrupt you later, just to say, if people have questions, you can email Zara or Arlene with your questions. So you can chat to Zara or Eileen in the chat box and send them your questions. Thank you.
Thank you very much, Arlene. So I'm just going to share my screen now to start. So as Arlene said, I am a GP in Oxfordshire and I was clinical champion for the Spotlight project, which ran for a year. And in that time we developed an educational program, GP workshops, and also the Lyme disease toolkit that we'll come to. And the key thing that I'm keen to get over today is the basics, what it is that is happening in primary care and what we need to do. Because really, although everyone thinks of Lyme disease as being quite complicated, it really is a primary care illness, and we hold the key to early diagnosis and early treatment. So my feeling is that our role in primary care is to raise patient awareness, and that means help them avoid tick bites and know when to present to us. And of course, they're not coming into the surgery at the moment because of COVID. So another option is to make sure you've got something on your practice website, just letting people know what to look out for, when to present, because they're so concerned at the moment, either not getting appointments or not bothering the doctor or the nurse, that they're not going to be coming in. And on that same point, they're probably not coming into the GP, they're coming into the nurse, or they're going to see the pharmacist. And in fact, I had four cases in July, and one of those was specifically referred by a pharmacist. Early diagnosis is key. So unless they're presenting early, even if they don't feel particularly unwell, if they recognize that they might have Lyme disease because of the rash, they'll turn up early. But then they risk not being diagnosed by whichever clinician sees them. So we've got to raise awareness in that area. In terms of treatment, the NICE guideline is what we should be following in the UK. And we'll come to that later. And accurate recoding is really important, because these days, if we're diagnosing more clinically, as NICE advises, there's going to be less evidence available. And within that, you need to be aware that, as well as, because it's so difficult to diagnose, as well as coding Lyme disease or EM rash, you can code suspected Lyme disease or suspected EM rash. And that's fine to do that. And it is important, because a lot of the time you can't be 100%. So recognizing late Lyme disease, this is the case where you may have patients who used to be really well, and now suddenly they've got multiple problems, seeing multiple consultants, and we may be the only people as specialist generalists who are picking up that there's an awful lot more going on than each consultant is aware of. And then patient support, 5 to 20% of patients don't recover, and this is based on peer-reviewed evidence from the USA and Europe. So we'll come to that later. Why is my... Okay, so this is the toolkit that we've developed, and the idea is that this should be a single point of access for everything you might need to know. You can easily Google it. It's open access to everybody. It's freely available to patients and clinicians. And we aren't able to keep updating it, but it has got most of the links to the information that you need. We're about to do a short update very soon. There's also an e-learning module with the RCGP, but unfortunately that's no longer freely available to everybody. It is only freely available to RCGP members. Other people have to pay. So I just want to give you a bit of a background. What I will say before, what I should have said at the beginning is, please don't feel that you need to write any notes. I'm quite happy for all my slides to be shared. And the whole talk is being recorded. So Lyme disease is caused by a bacteria, a spirochete called Borrelia burgdorferi, and it's spread usually by the bite of an infected tick, and is the most common tick-borne disease in Europe and North America. So it's actually been apparent to many clinicians within Europe over about the past 100 years. The connection with tick bites and rashes and paralysis and neurological symptoms was noted. But it wasn't until the 70s when it became more of an issue in the States that the correlation with tick bites and bacteria was noted. So the name Lyme disease, so it's not Lyme's, it's actually Lyme disease, and it comes from the town of Old Lyme in Connecticut, where a group of children, a large number of children, were being diagnosed with juvenile rheumatoid arthritis. And it was actually the parents who brought this to the attention of the authorities, because there were so many children, and it was subsequently found to be due to a tick-borne infection, which was subsequently shown to be Borrelia. And in 1988, Dr. Andrew Pashner, who's a neurologist in the States, described it as the new great imitator. And for those of you who aren't aware, one of the names for syphilis was the great imitator, and syphilis was a spirochete like Borrelia, which had primary, secondary, and tertiary stages. So it has multiple genus species. Only a couple of them are probably relevant within the Europe or the USA. But the different genus species probably cause different types of symptoms. In the USA, it tends to be more arthritic symptoms. In Europe, it tends to be more neurological. The testing is a bit complicated. It's a two-tier system where you send blood to the local lab. If it's positive, if that result is positive or indeterminate, they will send that off to the local Lyme unit, either at Public Health England at Porton Down or up in Raigmore Hospital in Scotland. So you can get false positive results, which is the reason they do the second test. But there is also the risk of false negatives due sometimes to the test being done so early or having had early antibiotics. And the key point is that Lyme, a negative test does not exclude the diagnosis. But unfortunately, many clinicians don't seem to still acknowledge this fact, even though it is part of now the NICE guideline, and they're still being sent away. Incidence is increasing. Lab confirmed cases probably only reach about 1,700 a year. Formal estimates suggest 3,000 a year, but some more recent research suggests it's probably anywhere from 8,000 to 10,000 a year minimum. So it affects males and females. It can occur at any age. And we know that there's a higher incidence up in Scotland and in the southern counties of the UK. And we know that ticks are most active between March and September, but it's now become apparent that there is some activity all year round, but the most likely time to get bitten is any time from March to September. And so, as I mentioned, there's more research coming out all the time, just looking at the patterns of the type of patients people who are becoming infected and the incidence. And this is just looking at the population demographics, and you can see that it can affect people of any age, from a baby left lying on a picnic rug in a park to a middle-aged person out hill walking to somebody gardening, so any age really. And the Big Tick Project looked at the risk of tick infection, and that looked at Scotland, south of England, Norfolk as being high-risk tick areas. So we know that ticks are small arthropods that are blood-sucking, and there are several species native to the UK. And this is a picture of the life cycle. So there are 3 stages at which they would take blood meals. First, the larvae after they've hatched, at which point the larvae aren't infected, but they will then feed off small mammals and birds, and then develop into nymph ticks. So the nymph ticks will be tiny, maybe the size of a poppy seed, but they could well be infected. And these are the ones that are easily missed. The nymphs will then feed either on, again, small mammals, birds, deer, but also potentially on domestic animals and humans if they happen to be within their environment. And then finally, the nymph will feed again. After that feed, the nymph will molt and become an adult. The adult ticks will again attach to deer, small mammals, and humans, but they're probably much more visible. So this is kind of habitat, but it's not necessarily rural areas. You will still see ticks because of the fact they carry on birds and animals. They'll be seen in your garden, in parks, so you're at risk in multiple areas. And although, because ticks are painless, their bites are painless, they inject anesthetic, they might go unnoticed. And although you think, well, you probably wouldn't miss a huge tick attached to your forearm, you will miss a small tick attached behind your knee or an area of the body that you can't see. But because you're bitten doesn't mean you'll get infected. The infection rate amongst ticks is anywhere from 0 to 16% in different areas of the country. And in the UK, they're normally, the infections are usually Borrelia guerini or Borrelia abscellae. The next question is this issue of time needed for transmission. And there is no proven minimum time. There are plenty of suggestions in the past that you needed to be attached for 24 hours, 48 hours, 72 hours. There is no proven minimum time. And if the spirochetes happen to be in the mouthpiece of the tick, then they will transmit more easily. Also, if the tick is removed traumatically, it may well regurgitate its contents into the person, even if it hasn't been attached for that long. The other issue is knowing how long a tick's actually been attached. The fact you've removed one doesn't mean there isn't another one you haven't noticed. Another thing to be aware of is that ticks can carry multiple infections. So patients may present slightly unusual symptoms, or they may not respond to the treatment for Borrelia because they've actually got more than one infection going on. And ticks don't fly or jump. They just wait on vegetation for an animal or a human to pass by, and then they sort of attach themselves, climb on, and then they do something called questing, which is where they move around either on clothing or on the skin till they find a nice warm place to attach. And as I said, because they're injecting anesthetic, no one notices. And you can see that tiny mark on the wrist there, which is a nymph tick, and why they're easily to miss. Whereas that huge engorged tick would be much more difficult to miss. If they do attach and they're not noticed, they will stay for several days and then they'll probably just fall off again. But the longer attachment, the greater the risk of infection. So one of our questions actually was whether children are bitten above the waist. And in fact, they are usually bitten above the waist. So that's what you need to be looking for, what parents need to be checking for. Ticks, they might be under the arms, it might be behind the ear, they might be in the neck, they might be in the hairline. Whereas adults are probably more likely to be bitten on arms and legs. And prevention is really better than cure. And it is really, the suggestion is shoes, long trousers, which we don't necessarily feel like wearing on a lovely summer's day. Light clothing, so you'll see the ticks, brushing the clothing off, showering afterwards to make sure you've checked for ticks. The other thing is to use maybe insect repellent on skin or on clothing beforehand to try and avoid the risk of being bitten, and walk in the middle of tracks, not through the long grass, and just be tick aware really. When you get home, be aware of checking children and pets, because pets can carry ticks into the house, which may then subsequently bite you, even if they didn't bite the animal at that time. And tick removal is important. It's a key issue. Once you've been infected, you need to remove it, or bitten, you need to remove the tick as soon as possible, but as carefully as possible. In the past, there are issues, suggestions such as smothering it in oil and waiting for them to fall off, covering them in nail varnish. I think lots of army people are quite happy, quite like the idea of setting fire to them with cigarettes. But the key is to get them off carefully, ideally using a tick remover or a tick card. And this next slide was just going to show you how to use a tick remover. So the idea is that you twist, not because the tick has a corkscrew head, but because it's easier to remove because it's got a brush effect mouthpiece. It doesn't matter whether you go clockwise, anti-clockwise, it's just to do it slowly and carefully. If you're using narrow tooth forceps, then get as close to the mouthpiece as possible, as close to the skin, and then just pull firmly. You don't twist with forceps. But they really are quite unpleasant. Many of you may have had experience taking them off your animals. So just looking at Lyme disease, the stages of Lyme disease. And these are described as early localized, early disseminated, late disseminated, and then the persistent symptoms, which are given a couple of different names, such as chronic Lyme, post-treatment Lyme disease syndrome, or post-treatment Lyme disease. And what I want to look at is how those patients are going to present in primary care. So they might come in asking you to remove a tick, though, as we said, it's probably less likely at the moment with COVID. They might come in sure they've got an EM rash. They might come in with an insect bite. And I would sort of highlight that every time you see a patient, we see a lot in the out of hours where the key information is insect bite. Try to have in the back of your mind, is there any reason this could be a tick bite? Patients will be able, if you go into more detail, as I'll explain in a minute, you can try and get an idea of whether this could have been a tick as opposed to a normal fly bite, horsefly bite, this kind of thing. They might just come with an unusual rash. If they come in, some of the times people are coming in having had a tick bite, they've removed the tick, they feel perfectly well, but they're panicked. They want a blood test, they want some antibiotics, they've been reading all about it, and you need to be confident in reassuring them that there is certainly no point doing a blood test. It's unlikely to be positive within 4 weeks of a tick bite. And if they're completely asymptomatic, there's certainly no reason to do a test. And there are only a couple of reasons why you might have to treat prophylactically. Certainly in some areas of America where there's very high tick infection rates of maybe 50%, they probably do treat prophylactically a lot more. They might come in with a history of tick bite, tick exposure, and now they've got a rash or they feel unwell, and that will probably be a lot more straightforward. But they might just come in the middle, even now, with vague flu-like symptoms. They feel exhausted all the time, they've got no energy, they've got aches and pains, they just don't feel right, and you need to go back to, well, when did this start? Is that, is there anything they've forgotten to tell you? Did they have a funny rash? Did they have a tick bite? And there might be the people who've become chronically ill, which is again where we mentioned earlier, just having that on your radar is to think about whether they've been tested. Also, the ME and chronic fatigue patients, have they ever been tested for Lyme disease? Previous history of Lyme disease, some patients will get recurrent symptoms, and other patients might come with blood tests from outside the UK and asking you to treat, and that's a very complex area that will be discussed at a later meeting. So if they come in with a tick bite, as I said, just try and know when they were bitten, where it was that they were bitten, where's the site of the bite, how long do they think it was attached, how easy was it removed, have they had any symptoms so far? If not, then give them advice on what to expect and to come back if they're unwell, and make sure everybody in the practice is on the same wavelength. There's no point one doctor or nurse telling them to come back, and when they come back, they get told, well, you haven't been to the New Forest, so you can't possibly have Lyme, or there's no Lyme in the UK, which is still what happens in a lot of places. It may or may not be appropriate to test, but probably not within 3 or 4 weeks of a bite is probably the earliest you might get a positive test, unless they're already quite unwell. Think about whether there's any indication to treat prophylactically. Maybe if they'd had multiple bites all at the same time, maybe if they had other ongoing illnesses, it might be appropriate. And if there's any clinical suspicion of Lyme disease, based on NICE guidelines, you can treat. So symptoms at the early stages may just be the rash. They may feel completely well, but the rash is diagnostic and you treat it, but it's only present in 70% of cases. They might have flu-like symptoms, aches and pains, neck aches often common, migrating muscle pain, joint pain. And the erythema migrans rash is not as easy as you might think. It's not necessarily a bullseye. It could just look identical to cellulitis or an allergic reaction. It probably occurs 3 to 30 days after the bite, and it's usually painless, but sometimes it could be a bit hot or a bit itchy. And don't be misled by the patient. You want a clear history. They may assume they just had an ordinary insect bite, but you need to go into detail. And if the rash has gone away, but they've got a clear picture maybe of what it was and that they know the story, that doesn't mean the infection's gone. You still need to treat even if the rash is gone. And remembering, as I said before, they may go to the nurse or the pharmacist. So that's a typical rash. It would be difficult to miss that one, but it's not always at the site of the bite. And there are a couple of others that can be quite unusual. They may even be multiple once the infection is disseminated. And the bacteria can disseminate around the body quite quickly. So as I said, when someone presents with an insect bite, get some detail. Is there any chance this can you honestly say this is an allergy or cellulitis? Does it need to be a diagnosis of exclusion? And maybe you need to have a shared decision-making process as to whether you start antibiotics. So these are the kind of symptoms you get into the disseminated stage, which can occur very quickly within weeks, but it may take longer. Facial palsy, every time you see a facial palsy, think about whether this could be Lyme disease. They may get palpitations, chest pains, breathlessness, and anxiety seems to be a part of the actual illness rather than just anxiety about being unwell. It seems to be a symptom. Severe unexplained pains, neuropathies, even meningitis. And patients may not give you all the history. It may need some detailed questioning to get the full history. In terms of treating facial palsy, you've got to think clearly about that one. If you can clearly know that it was Lyme, you can treat with antibiotics. If you don't know, then you're going to have to think about whether they need steroids as well, because it really wouldn't be acceptable to assume it might be Lyme and then it turn out not to be. So late or persistent symptoms could be really anything. All sorts of different symptoms can occur, weeks, months, years. And sometimes they're so random and so varied that patients get diagnosed with functional disorders or psychiatric illnesses. Children might be particularly difficult because they just become a bit tired, fatigued, maybe they develop neurological symptoms, maybe their behavior changes, whether that's teenagers or young children. And sometimes it's when something else like a facial palsy develops that you suddenly get the diagnosis in young children. And it's been described as the new great imitator because it's been misdiagnosed as many of these other conditions or difficult to differentiate from these. Particularly, I'm aware of a consultant, a doctor in America who was diagnosed with motor neuron disease 15 years ago, subsequently found by 4 consultants, subsequently found to have Lyme disease and recovered. So if it's on your radar, you're much more likely to think about it. I'm sorry, I'm going to have to speak quite quickly now. So the NICE guideline, the positives are, it says the EM rash is diagnostic, you treat it. You don't need a blood test, you just treat, even if it has to be a suspected rash and you've discussed with the patient. You can treat based on clinical suspicion, even if you're waiting for a test to come back. The actual guideline, the timing of tests and things you can find from the toolkit. So what they suggest is you take a blood test. If it's negative, you should wait 4 weeks for the next blood test. But on the other hand, if your patient is ill, do you really want to wait 4 weeks? You could still do the test in 4 weeks, but you may need to get on and actually treat. Minimum 21 days of treatment and give a second course if they're still unwell, and a negative test, as we said, doesn't exclude the diagnosis. But there is limited evidence base for these guidelines and no recommendations on persistent symptoms. Testing you send to your local laboratory, it comes up under Borrelia, not Lyme disease. And you can speak to the Lyme labs if you're not quite sure about the information. The first test will come back in 24 hours. If they've sent it to the main lab, it will take possibly 2 weeks. And neuroborreliosis is much more difficult to treat sometimes, to diagnose sometimes, because an MRI doesn't exclude it and CSF findings can be variable. Treatment, I'm not expecting you to be able to read this. You can click onto it easily from the toolkit. And early treatment is the key. Children, the advice is discuss with a specialist if you've got more than just a simple erythema migrans rash, but don't delay treatment in the meantime. Adults, first line is doxycycline because it treats co-infections as well as Lyme, but at a higher dose, 100 milligrams twice a day. If it's amoxicillin, it's 1 gram 3 times a day. So it is a higher dose. Jerax-Herxheimer reaction is sometimes a reaction to the antibiotics, but it may come on within a couple of days, but it should settle, and it's normally just an exacerbation of symptoms. Plan to review at 3 weeks because they may need further antibiotics, and if they've got significant symptoms, they may need admission for IV antibiotics. Children need much higher doses, so you're doing about 30 milligrams per kilogram in a child of in children under the age of 9, or even over if they can't take doxycycline. But doxycycline is first line in age 9 to 12, which isn't it for most infections. It wouldn't be recommended first line, but it is in Lyme disease. But high doses based on the guideline. Specialist advice from the labs or the local consultants, but there are no specialist clinics. And my experience is that most secondary care consultants, Dr. Lambert excluded, have limited experience of Lyme disease, and they will readily admit this. So I don't think they can be considered any more expert than many GPs. Other guidelines include ILADs, which suggest much longer treatments and to retreat if symptoms recur. European guidelines are aware of the limitations of the guidelines that are available. Infectious Diseases Society of America have very restrictive guidelines, which have been an area of major dispute. And what about persistent symptoms? Patients are being told that chronic Lyme disease doesn't exist and it's all in the head, and they've just got the aches and pains of daily life and go away and we can't really help you. But actually there's a lot more evidence now than there was. And if for those of you who want to read more, there's a lot of research coming out of Johns Hopkins. Johns Hopkins University in the States is well respected, and they're doing some very, very good research. Columbia Lyme is another Bay Area Foundation. Lyme Foundation is over in California. A lot of the limitations are based on 4 randomized controlled trials, which state that there is no evidence just to support extended courses of treatment or retreatment. And this is a report where they biostatistical analysis review suggesting there is evidence and the need for more research. Now, why have I suddenly lost my, I've suddenly lost my files. What have I just, oh, I see what I've done, sorry. I have suddenly lost, because I clicked on a link accidentally, I have suddenly lost my, hang on. Okay, good. Sorry about that. So, as Dr. Lambert mentioned, there's about 500,000 cases a year in the USA now, probably at least 10,000 in the UK. And we know anywhere, we've got, I've said 10 there, but it's actually 5 to 20% of cases, even when they're diagnosed at an early stage with an EM rash, will have persistent symptoms. And that's estimated to suggest 2 million cases a year at the US at the moment of post-treatment Lyme disease. And the research coming out of Johns Hopkins shows that although physical examination seems normal and lab tests seem normal, a bit like long COVID, these patients are very, very unwell. And there is evidence to support that. So Johns Hopkins have defined a group of patients with what they call post-treatment Lyme disease. And they've postulated that this is a combination, that maybe some people have persistent infection, maybe it's a genetic response, an immunological response, an immune response to the infection. But they've been keen to point out that it implies post-initial infection. Post-treatment Lyme disease means post-initial treatment. It does not necessarily mean post-infectious. And the risk factors for this will be delay in diagnosis, which is where we come in, the severity of the initial symptoms, which may be a result of delay in diagnosis. And if patients have neurological symptoms, they've got much less chance of recovering. So the other area to think about is, like, any patients have persistent symptoms but never been diagnosed with Lyme. Many patients might have been diagnosed with COVID at the beginning of the epidemic, of the pandemic, where there was no testing. Maybe they had very vague symptoms. They're assumed to now have long COVID, but maybe no one ever thought about testing for Lyme. And think about non-Lyme causes, because you wouldn't want to miss any of those. It's important not to get blinkered by the thought that this is all Lyme disease. So the key points are, it's complex, testing is unreliable, early inadequate treatment is where we come in, even if diagnosis has to be suspect rather than absolute. And there's no international consensus on treatment. The EM rash is diagnostic, and if you've got unusual symptoms, think about Lyme. If patients ask about Lyme, then take them seriously. And if they request a Lyme disease test, I can't think of many reasons to refuse one, really, and exclude other diagnoses. There is something I very quickly need to mention at the end. So, sorry, my last thought was to suggest, think about developing a Lyme aware practice where everybody else is in the same, the practice is in the same wavelength. Think about doing a practice audit, quality improvement activity, look at how many cases you've got, look at if that picks up once everybody's more aware. And in May, there is Lyme awareness, and there are leaflets and posters available. At the end, Arlene is going to put up a contact detail for Lucy Delaney at the University of Liverpool, who is looking for practices who might be interested in becoming involved in some research, basically when they diagnose a case, having the facility to take photos, to upload information and improve practice primary care outcomes. So that's the end of my presentation. I'm sorry that last bit was a bit rushed. And all of this will be remaining online, and I would recommend you to look at the toolkit and use that as a day-to-day aid with patients. Thank you very much.
Thank you very much, Anne. That really was a whistle-stop tour through the world of Lyme guidelines, wasn't it? I think we could have listened to Anne for the same time again, actually, but the important thing is you now know where to find the material. So the RCGP website has it all. And also there's links from the Lyme Resource Centre to all of the toolkit and the NICE guidelines and all that you need to know. So remember to put your questions in the chat box to Zara, Hussein or myself, Arlene Brayley, and we'll answer those at the Q&A session later on. So Anne, thank you for that. It's now my pleasure to introduce to you Rachel Llewellyn. Now Rachel is a GP in North Somerset, and in 2019 Rachel also became involved in the Lyme Disease Spotlight project that Anne talked about, mainly as a result of her own personal encounter with Lyme disease. So she's going to tell us more about that experience as both a GP and a patient. Over to you, Rachel.
Thank you very much. I'm just going to share my screen now. Here we go. Okay. So I'm just sharing. So I pre-recorded this in the today in the interest of keeping to time. So.
Okay, we cannot hear it, so just give us a second. Can you pause it and I'll try and adjust?
Yeah.
So leave it on so that we know if I've got this fixed.
Okay, I can always just do it live if necessary, Gordana.
Yeah, it might just take a second. So if you put it on, and I will.
I'm just going to see if I can. You share.
Okay, we'll stop the sharing just for 1 second.
So while Rachel and Gordana just sort the technicalities, always a hazard of online webinars, isn't it? And you'll see that we've put in the chat box, I've put in the link for Lucy Delaney, the researcher at the University of Liverpool. So any of you that are interested in that, do feel free to get in touch with her. And Zara has also put in the links for you, both links to the NICE guideline, 95 I think it is, and also links to the Lyme disease toolkit. Definitely worth a look because that has everything there that you need in bite-sized chunks, as it were. So I hope that you'll find these really useful to keep for later on.
So Rachel, would you mind trying to share again?
Okay, we'll try it one more time, and otherwise I'll revert to going live. So share screen.
I think you might have to to give it live, Rachel, because I'll fix it, but it will take me a little bit of time now to fix.
Okay, that's fine. That's fine. I'm so sorry. I'm just going to restart then, and I'll access my slides without the voiceover, and I'll just be speedy. So,
Thank you everyone for your patience. I've heard Rachel's talk before and it's worth waiting for, I can tell you that, because it's an unusual take from both a patient and a doctor.
okay, so can you hear me, everybody? Can you hear me better now?
Yes,
Can
that's
you hear me?
perfect.
Lovely. Okay, so I'm sorry about the technical hitches, and I'm going to sort of be as speedy as I can then. So I'm a GP, and in Somerset I've had personal and professional experience of Lyme disease. I have had Lyme disease twice, and also since that have been more aware and have seen a lot in clinical practice. And a bit of background, I have an interest in dermatology, which of course is relevant, and a long time ago did my degree in microbiology when I intercalated, and have been involved with lots of outdoor pursuits. And I really thought I knew about Lyme disease, and if anybody should have known, I should have known, and you'll see what I'm about to share with you, that I came unstuck really. So why raise awareness about Lyme disease? So GPs and other frontline clinicians, we are so critical to facilitate early diagnosis, and we are missing it. Diagnosis can be really challenging. There are hotspots, and it can occur anywhere in the UK. But my particular experience was that within just weeks, 4 of my immediate social circle contracted Lyme disease, and we had diverse presentations. And this little cluster of my friends just made me realise how what a clinical conundrum this was really, and quite how complex this illness was. And not just that, but my experience as a patient was truly harrowing, but doesn't even scratch the surface of the experience of some. And so I really felt a duty to sort of share my experience from both perspectives. And this is just a quick slide to sort of show there's a deer, but I live on the edge of woodland, and yes, we have deer, and what deer do is they increase the numbers of ticks in the environment because they're crucial to the mating cycle of the tick. So loads and loads of ticks if you've got deer, but deer don't harbour Borrelia. It's the little mice and the birds and the squirrels and other little vermin that just trap in and out of the woodland edge on or the habitat transition. And I think that's why so many of my friends were affected, because we live in this habitat transition. And therefore I think if here, I think I would have a low threshold for prophylaxis because of that particular zone that we live in. And these are nymph ticks, and you can see from here how easy those would be to miss. I mean, they are the stage of the tick life cycle most likely to bite and transmit Lyme disease. And you can see this is why we are told to wear white trousers in the woods. You just wouldn't notice that unless you were looking for them. And this is my friend that I've already mentioned. So she happened to have a tick bite on the same day as me, and presented about a week later with fatigue and neck stiffness. As Anne mentioned, it's quite common to get neck stiffness. A few days after that, noticed this bullseye rash at the site where the tick had been, and she went to see the local her local GP surgery, and the clinician that she saw wasn't sure and sort of wanted to adopt a watch and wait approach and turned her away. And she was meanwhile getting more and more unwell, and it was her son who knew what she had and sent her back, because he was at the age of 15, he'd done his work experience in year 10 on the Mendips and had seen a poster. So that was rather harrowing that it was the 15-year-old that made the diagnosis. And this was somebody else in my woodland edge garden last year who went a couple of weeks after this gardening episode, went to the GP with this rash. Didn't tell me about it, but the key point I wanted to make was that this is a very obvious part of the body on their lower anterior shin. No tick had been noticed by this person at all. So she went to the GP and said, well, I know it's not Lyme disease because I haven't seen a tick. And that, Anne talked about not being misled by our patients. And quite understandably and quite reasonably, the GP did give a course of flucloxacillin, but the rash continued to spread. And at that point, she mentioned it to me, and we established this was Lyme disease. And thankfully, she did respond to the doxycycline for the 3 weeks. So this was a friend's son a few years ago, who he had a really nasty bout of Lyme disease, ended up in A&E with sort of meningitis, really. But he had flu-like illness for 3 days, and then mum noticed this rash, which then disappeared. She was an experienced nurse, and she clocked it and she took a picture. I don't think she realised the significance of it at the time. But my question at this point to you would be just to think, what if this child had long hair? So if this was a girl with long hair or a boy with long hair, would that have been noticed, and would there have been a delay? And it's important to make sure that we get people to tick check under hairlines in children. It's really common. So this is another child who presented with an insect bite behind the knee. Mum felt there had been something embedded in it, but and it looked infected. So quite reasonably, the GP gave a course of flucloxacillin. But Mum was really convinced this was a tick, and the child was really getting more and more unwell. And Mum knew there was something not quite right. So she kept going back, and it took her 6 times and 6 visits to the GP to get the antibiotics for Lyme disease. But you can see that there's an evolving erythema migrans here, and it's about making sure that we're aware of a possible dual diagnosis here. I think this is something that catches us out a bit. So again, just to recap erythema migrans, because it's so important, is that it's a migrating redness. That's what it means. It can present anything from 3 days to 3 months after the tick bite, and although most are within 4 weeks or so, it can take longer, and it's so variable in appearance and behaviour, and it's not always a bullseye. And as Anne said, a third of people don't even have an EM rash. But what it is and I find this really helpful to remember, is that it's the immune reaction to the migrating spirochete that migrates out from the site of inoculation, and the immune reactions amongst individuals vary, and of course we're more aware of that now than we ever were, given the last 18 months and the COVID pandemic. So that is just something that's helpful that I remember. And again, just to reiterate, it can disseminate early. It's been isolated from the salivary glands of ticks. It can disseminate early. The early treatment is often effective, very often, and Borrelia isn't the only organism, so therefore we need to cover with doxycycline first line if we can. And this I find really helpful. I've got this printed on my wall in my GP surgery. It's the BMJ infographic, nice and colourful, and it gives you the schedule of doses, and it's quite easy to reference and access. So I've got that certainly in the summer. So I've got a case initially of one of my patients who I saw. Well, she initially presented to the emergency department when she had been playing in the woods, became a bit unwell. A few days later, and Mum noticed a rash. They didn't remember a tick bite, a tick attached at all. It's just that there was this rash, and fever, headache, tired, tummy ache. Amazingly and brilliantly, the ED clinician diagnosed erythema migrans and prescribed amoxicillin for 21 days and advised to see the GP in 3 weeks, which was all very good. But 3 weeks later, she was still unwell. She was only just managing school, fatigued, really hot and sweaty in the evenings, really poorly. Mum was worried. And so at that point, I thought, oh my goodness, what's going on? And I asked Mum to check the dose that she'd been given, because there was no dose on the discharge summary. And she'd been taking 5 mils of the 250 milligram syrup 3 times a day, so just a quarter of what she should have been having. And there was no other explanation for her significant symptoms, and so realised at that point that she has had partially or sort of insufficiently or untreated Lyme disease. And so actually, according to the guidance, doxycycline is first line in a child of that age. So we commenced doxycycline, And I did refer to a paediatrician, but 1 week later, she was even worse. She was sleeping all the time. At that point, she couldn't get out of bed, and I was getting really quite worried about her. But I spoke at that point. I actually phoned the paediatrician and we discussed this, and we agreed this was almost certainly a Jerisch-Herxheimer reaction. And because of my concern about the delay already, we agreed to use amoxicillin and full dose doxycycline together to avoid the delay. And she made a brilliant recovery, which was just wonderful to see. And in sort of treatment of Lyme disease, it always brings me back to the wisdom of William Osler, who was in first year of medical school. I remember being quite inspired by him and the quotes that he put forward, and the clinical acumen and the that he had to display pre-testing. And I have sort of patients where that's with Lyme disease that I've had to take that approach, and they've got better, and it's not following testing or and I think where there are uncertainties, so it's going back to first principles. And so my story, why tell it? So I think my concern from the very beginning was that I had a really atypical presentation with negative serology, even at quite a late stage. And if I was not a doctor patient, I wouldn't have known what I had. If I hadn't connected the tick bite to my symptoms, I would not have known what this was. If I hadn't known I had a tick bite, I wouldn't have clocked it. And if I'd have had a patient come to see me who hadn't raised tick bite, I don't think I'd have made the diagnosis either. And that really concerned me, because I obviously may well have become really much more unwell had I not got it as early as I did. And even as a doctor patient with late disseminated illness, my experience was quite harrowing, and it taught me a lot about doctor patient interaction and about, well, I'll share it a bit more here. So I had a tick bite, knew all about it. The photo was just on the previous slide, and it lived in my freezer for about a year after that. The tick was there probably for less than 16 hours, and I removed it really safely. I thought I'd be fine. I really thought it was low risk, and I did check for an EM rash for the 4 weeks or so, nothing obvious, and I forgot all about it. Absolutely fine. I was well. Until about 7 weeks later, when I was in my afternoon surgery and my lips started to twitch. I noticed I had to bite my lip to stop my lip quivering. I remember thinking, I wonder if the patients are noticing what I'm doing. I wonder if they can see my twitching. And then over the next 3 days, I got progressive twitching periorally of my calves, of my hands, and I began to develop insomnia, which is really unusual for me. I never had a problem with sleep, and also some tongue numbness and some right-sided facial numbness. And it was all rather concerning. But after about 3 days, I had a light bulb moment, and I remembered the tick bite, and I managed to connect the two and realized I had neurological sort of sequelae of Lyme disease, and that this was now early disseminated. It was all sort of progressing by the day. And when my daughter took a picture of my back where I'd had the tick bite, there was then a very faint EM rash. And there it is. You can see just about the punctum just in the top right of the little the triangular sort of shape, and the edge at the bottom. But this was about 8 weeks after the original tick bite. It's faint. You can barely see it. It's small. It wasn't anything like my friend's leg, who had this horrendously, this awful rash, and so clearly my immune reaction was very different to hers. I did have a widespread rash visible after a shower, and I did start doxycycline, and my symptoms definitely attenuated. They didn't go completely, but they attenuated. And then after that 4 weeks, within days of stopping, I started to get a relapse with novel symptoms, and I got new chest pain, new twitches, palpitations, more neurological symptoms that seemed to be progressing sort of proximally. And so I had another course of doxycycline, and again, all settled down. It seemed really antibiotic responsive, and I had other sort of symptoms that were suggestive of a more significant illness. And I was beginning to get a bit tired at that point, and it felt to me like a very, very active process. I wasn't expecting not to get better after that first 4 weeks. So it was disconcerting to still have those symptoms. And I asked for a referral, which my GP thankfully did. I knew I had disseminated disease, and I started to read an awful lot. And I was struck at that point. So although I had an EM rash at 8 weeks, my GP did do a serology, which technically wasn't necessary because I had a clinical diagnosis, but I'm really glad she did, because it was negative even at that stage. And then when I did end up in the infectious disease clinic, it was negative again at 14 weeks. And that, although I had antibiotics at that stage, but that really raised to me how I knew I had Lyme disease. I had an EM rash at the site of the tip. There's absolutely no question about the diagnosis, but my tests were negative. And I think this was something that really needed to be talked about, because I saw how people were being dismissed with negative tests. And when I subsequently did have a test done privately, there were some faintly positive bands, which I do think would have been dismissed as a false positive had it been done, but I knew that what this was, and it raised lots of questions for me, because I presented late, had a very faint erythema migrans. I was clearly unwell enough to lose weight and lose hair, but no antibody test. Why was I still having ongoing symptoms? And I read and read and read about this, and I came across this very excellent review article. Oh, this is a more recent review article actually, but I read and discovered that the biology of Borrelia as an organism is incredible. It's one of the most complex bacteria known to man. It's a master of disguises. It's designed to persist, as you know about the life cycle in the mice. It targets immune privileged sites. It both evades and suppresses the immune system, and that made me think, goodness, in me, with my particular genetic profile or whatever, with a particular strain, has it suppressed my immunity such that I'm not raising a response to it? It's very clever if it's doing that, but that's why I'm not raising a response. That's why I'm testing negative, and I think that's got huge clinical significance for patients potentially, and I don't think that is talked about enough. So it does cause hugely variable disease. We know about these 3 different strains that all present slightly differently clinically. So Guerini is more neurological. Begdorferi is more of an arthritis picture, although there is crossover. And of course, co-infections complicate the picture. And knowing about this, I mean, what would you have done if this was you? If you had symptoms that were antibiotic responsive, that were not settling, and then as soon as you stop the antibiotics you get worse again and you feel it's very active, what would you do? And what do other doctors do when they get Lyme disease? And I certainly wasn't the first doctor to go and seek private treatment and have that sort of elsewhere outside the NHS, and that's got massive implications for our patients too. So from a patient perspective, that evidence is lacking. People get really poorly, all of this, that people get better with other treatments, whether that's herbalist treatments or prolonged antibiotics in some cases. Lots of things people do report getting better, and it's not just a few people, it's big numbers. And so one takes that seriously when one has this illness. And I know that absence of evidence is not evidence that it doesn't work, lack of research, disagreement amongst medical professionals. And I very much sensed that in my appointments with my clinicians, I've had it twice, that there just wasn't enough time to engage with them. It was very clear that the clinicians that I saw, they were time pressured. They thought I was anxious. They just didn't know what I was going on. They didn't understand why I was so concerned about it, and I didn't feel heard, and I did feel quite belittled, even as a doctor. And I've only just really begun to be able to name what this was, but there is a phenomenon called medical gaslighting, and it's something that I think we could all fall into the trap of, even on a subconscious level because of our training. And it's something that I certainly would want to be very, very aware of. And I know that this happens. It definitely happened to me. I've seen it happen to others. And especially with a disease like Lyme disease, which is so poorly understood. So I felt dismissed, questioned and scrutinised. I perceived that there was a lack of curiosity, probably because of the time pressure, and that there was a lack of willingness to discuss the uncertainties. My clinicians really thought, well, you know, they seemed very certain that I was going to be fine, when what I was reading suggested that maybe that wouldn't be the case. If I and they said things like, we don't know what your symptoms are, but we know they're not serious, and you're just anxious, you'll be fine, and these symptoms might not even be Lyme disease, and I want you to show me a photo of your rash and send it to my secretary, as if they didn't believe me, even though I'm a clinical assistant in dermatology. So it did feel quite challenging and difficult, and I felt really disempowered even as a doctor. And I was informed in no uncertain terms that antibiotics are not a treatment for neuropathy, you know, and I thought, well, I'm not silly, I know that, but I was just explaining that my symptoms were very, very responsive to antibiotic treatment, but I was said, absolutely, you've had more than enough treatment, you'll be fine, you know, off you go now. And it felt quite difficult. So gaslighting is a form of manipulation when someone's made to question their sanity, perception, reality, or memories. And it's common in intimate relationships in the context of emotionally abusive partner relationships, but also in social interactions where there's an imbalance of power. And of course, in the doctor-patient relationship, sadly, there sometimes is an imbalance of power, much as we try to mitigate that. And with our modern training, I think we do a lot of the time, but there are but there's no denying that that still happens, especially within the constraints of a consultation that's time pressured, when you have a huge pressure and a backlog of patients to see, and sometimes people with very unreasonable expectations and demands. I think sometimes this is a trap we can, as I say, fall into as doctors. But actually, a person on the receiving end of this behaviour is experiencing abuse, essentially, and that this is a really harrowing concept, really, for me. And the techniques that happen within gaslighting, I think I experienced all of them in my medical consultation. So countering, sort of questioning the history in a negative way, sort of quite disparaging. Are you sure that happened? I mean, how do you know? And then withholding, sort of refusing to engage in dialogue, partly because of time pressure. I mean, sometimes we just have to do that as doctors. Trivializing, and you know, belittling experiences, thinking, oh, you're just anxious, you know, or maybe it's just stress, or changing the focus of discussion, or stereotyping. So they said, well, lots of doctors, when they get these twitches, think they've got motor neurone disease, you know, they're there, you'll be all right. Or, you know, women of your age, you know, often have sort of non-specific symptoms like this, and it's menopause, or, you know, that sort of attitude. So it was, like I say, quite disempowering, even though these were clearly good doctors who excellent at their, you know, in their roles. But I found it very, very sad, really, to come away feeling the way I did. And as a doctor, as I say, I think we do know that this is very difficult, very easy for us to fall into the trap, and very difficult when you've got challenging patient with unexplained symptoms. But I think sometimes symptoms are medically unexplained simply because we haven't got the diagnosis right, and we do have to be aware that trauma can cause some of these symptoms, and there is certainly psychosomatic illness, but I think that can sometimes be used as a blanket, and sometimes we need to think, is there anything else going on? And I think Lyme disease is one of those classic things where you could label a patient as having psychiatric symptoms, and actually they are. You know, they're actually suffering with an untreated disease. So, you know, what often happens is they told post-treatment Lyme, and that's it. And we expect them to improve, or they then a doctor may refer to another specialty, and these people end up going through specialty after specialty on a quest for an answer that never comes. And my combined doctor-patient view is that these patients are potentially lost to follow-up, because perceiving that they've hit a brick wall and that they're not being listened to, they often do seek treatment outside the NHS, and many do report good outcomes, but these outcomes are not being captured, positive or negative, and that has huge implications, and we are missing catching them, we're missing keeping them safe, we're missing learning what is actually working. because they are just dismissed from clinics, I think, and then they go elsewhere and nobody ever knows what happens to them. Assume they get better perhaps, but they don't always. So more research is urgently needed, and we as doctors really need to collaborate with our colleagues in all the specialties and in other disciplines to share information and the management of these sort of complex patients. So I think it's all about talking, it's all about transparency and humility and science, looking at the research, what's it really telling us, without any of us having sort of an agenda. And I think the solution would be a specialist clinic, with multi-specialty and multidisciplinary collaboration, with open discussion and long-term follow-up of patients and development of clinical expertise that way, and of course research, because there are still uncertainties. Thank you.
Rachel, thank you very much indeed. That's a really powerful talk, isn't it, that we've just heard from Rachel, highlighting the difficulties and the complexities that we can all meet in trying to get to that all-important diagnosis and get it right, and get the treatment doses right, length of treatment. But I think the bit that sticks with you, as it may do, is the fact that when she went through that experience, it's a kind of perspective changing experience, and I hope it's perhaps got us all thinking with a more open mind about how it felt to be a patient going through that. So I know you've been putting your questions in the chat box, thank you for doing that, and Zara has been collating them. So let's move straight to the questions if we can then. We have Rachel and Anne here with us. We've also got Professor Lambert and Dr. Zara Hussain. She's been doing a great job collecting them for us. So if I just start off, I think that the first few questions obviously came during Anne's presentation. Anne, when is the ideal time to test if the patient can be tested too early, as you talked about?
Well, the NICE guideline advice obviously is that a patient is asymptomatic, there is no indication to test. I would say that even if a patient became symptomatic within days of, ideally it's probably unlikely they'd be test positive before 2 weeks, but if a patient has symptoms, it may well be worth testing at that point, but you need to be aware that it might be negative. Of course, there's always a possibility that that was the tick they saw and they've had a tick bite several weeks previously or something as the cause of the symptoms. So the NICE guideline says test if patients are symptomatic. If they've had a test within 4 weeks of the bite, then wait another 4 weeks after that test and then do another test. But I think every time, on top of that, there's the issue that whenever you're doing the testing, you can go on and you can instigate treatment if you feel it's clinically indicated. I don't know if Dr. Lambert has any other suggestions on that.
You're on mute, Jack.
Okay, so I'm not in mute now. I've never, you may want to mute me, but the point is an antibody test is an antibody test. We have people with negative antibody tests who are infected, and we have people with positive antibody tests who were infected 10 years ago and are now 100% cured. So you have to, it's a clinical diagnosis, and the antibody test can be supportive, but you shouldn't be, you shouldn't be hanging your test, you shouldn't be hanging your diagnosis exclusively on an antibody test, which is imperfect.
Thank you. So, that's the sort of summary of it. It's helpful in the toolbox, but it's not the key thing. And if you've got supplementary questions to these, please do send them off in the chat box. Here's the next question. If the rash has improved, but it's still present to a lesser extent after 3 weeks antibiotic treatment, do you treat for longer, or do you accept that it's a resolving rash and reassure the patient?
If you're asking me, I would say I've heard two sides. I've heard from the American doctors who say if there's still a rash, keep treating. UK doctors have said don't give any more treatment, it's resolving. But again, I'd like to know what Dr. Lambert's opinion is on that.
Well, I can just give you an interesting anecdote. A GP from near Liverpool had a rash, had a bite, saw the tick, had symptoms, got the treatment, felt better. And then 2 years later, the rash came back again. And they actually biopsied the rash at a research facility in the Midlands at one of the universities, and it grew Borrelia. So there's, there can be persistent infection in the presence of a rash. So we don't have availability of PCR for Borrelia, but this particular case, even 2 years later, there was still, the rash came back again. And when they biopsied the rash, there was active replicating PCR proven Borrelia present. So, you know, I would say that if there's still a rash present, and especially if there's still symptoms present, it kind of implies persistent infection. The guidelines say 3 weeks, but these are guidelines. Not everybody gets better in 3 weeks with other infections. So I think you need to use, like Osler says, you need to use clinical judgment. You need to listen to the patient.
Thank you for that. Thank you for that view. And here's a slightly related one. If a decision has been made to treat for Lyme disease based on rash or symptoms, and the patient returns 6 weeks later wanting a blood test to confirm if they had Lyme disease or not, is this a reasonable request? Rachel, would you like to start off with that one?
Sorry, Eileen, could you just repeat that question?
If a decision's been made to treat for Lyme disease based on the rash or symptoms, and the patient returns 6 weeks later wanting to have a blood test done to confirm whether they actually had Lyme disease or not, would that be a reasonable request? It's presumably a GP asking this question, and
No,
asked this
no, I mean, based on sort of my experience and also the guidelines. I mean, if you've had erythema migrans, you have Lyme disease, the test may well be negative anyway. Once you've had antibiotic treatment, it probably will attenuate any antibody response, so it's very unlikely it would come positive. If you have an erythema migrans, you have Lyme disease, and the NICE guidance state that, so there's no need to do a test at that point. I hope that answers the question.
Thank you for that. Dr. Lambert's nodding. And here's another question, I think, Anne, probably for you. Up until what stage are the antibiotics effective? It's quite a wide open question. Up until what stage are the antibiotics?
I think that's a problem. It's a question for Jack, really, because I think we're not able to define that.
Yeah. We don't know. I mean, the current guidelines only address early Lyme infection. You know, if you see a tick, if you start to develop symptoms, if you see a rash, you start to develop symptoms, you treat with 3 weeks of antibiotics. If you're continue to be unwell, you give another 3 weeks of antibiotics. But what if you don't have the rash? What if you don't remember the tick, but you're kind of environmentally exposed, and then all of a sudden, a year later, you start developing symptoms, and this happens, you know. There is no guidelines for the treatment of longer duration of Lyme disease. The only data there is data from the American literature of people with late Lyme arthritis. So these are people who don't develop symptoms or develop persistent symptoms late down the way. The 3 weeks of antibiotics don't work in that situation. Studies have shown that you need to treat for up to a year in studies with people with late Lyme arthritis. So these are people who had a tick bite, who didn't do anything about it. And then almost a year later, they just started developing symptoms of arthritis. And then they were proven to have Lyme arthritis. 3 weeks of antibiotics didn't work in that situation. But there is no guidelines. The current NICE guidelines only address early Lyme disease. And I think that is the tip of the iceberg. There's lots of people, for example, you know, Arlene's son, who didn't present till later. The guidelines are, there are no guidelines. So I just think better research, better understanding. We don't prescribe. You know, I have patients with lymphedema who get cellulitis. The guidelines say treat 10 days with antibiotics for cellulitis. The people with lymphedema, they don't have good clearance of infection. They sometimes take 4 to 8 weeks of antibiotics to clear. So I just think we have to like treat patients, not treat guidelines. So I think that's true for every other disease. But for some reason for Lyme, it's, you know, some of my colleagues say, you've had your 2 weeks of antibiotics. If you're still sick, get over it. Well, you don't get over it. You don't get over a bacterial infection by telling people to use their willpower to resolve an infection. In some situations, you need longer courses of antibiotics.
Can I just say that if the question is there a point at which you've missed the boat? I don't think we can say that there is a point where it's too late. I personally treated somebody who had developed Lyme in childhood, been absolutely, definitely confirmed with multiple tick bites and definitely in rashes, but for some reason told you don't need any antibiotic treatment for this, it'll go away by itself. He remained ill till his late 20s and only came to the clinic under duress. He wasn't convinced, he wasn't sure anything would help him. As a trial of treatment, the tests were all negative. After a trial of treatment, after a month, he said, you know, I think I might be working out what it's like to be normal. I think I'm starting to get improved. And this wasn't placebo. He wasn't convinced. He only did it to keep his mum happy. Now, that wasn't the answer. That wasn't the fix. But after seeking further prolonged treatment, a year later, he went off traveling around the world. Now, he'd been very, very sick for a long time. So I think there are people who can respond. That may be a temporary and fluctuating response, but there are people who will respond a long way down the line.
Thank you very much, Anne. Yeah, it just highlights these are real stories, and you know, there's nothing better is there than just hearing the reality of it. Now, we do have a few more questions actually that have come in. I did promise you though that we would formally finish around now. So what we'd like to do is run that quick quiz, that poll again, in the hope that you'll participate. It's anonymous, remember, and hopefully there'll be fewer don't knows this time. So we're going to run the poll, and then for those of you who want to stay on, our speakers are staying for another 15 minutes and they'll be happy to answer the remaining questions that are there. So here we go, same poll as before, see how you get on this time. Just to remind you, it's all anonymous. It just collates the answers together, and helpful for you to see, and helpful for us to see if the session has made a difference. It's quite interesting actually. The don't knows have virtually disappeared, and we have a lot of agreement on the answers. So that's a very positive outcome. But I think importantly for you, I hope you're reassured that what you've heard tonight has helped you to acquire that knowledge and understanding of some of those basics that you're going to need in practice. We'll just leave it for another couple of minutes. I think most of you are just about there. I can see there's a few more of you still working away at it. And while you're finishing that, this is a good time for me just to thank everyone who's been involved in running the session tonight, particularly Gordana and Tina behind the scenes, and our speakers for giving up their time freely to come and do this. We have recorded the session, as you know, and it's going to be available through the Lyme Resource Centre website and the slides, and we hope that you'll want to go back and go over it again, and perhaps get your colleagues to look at it too. So at this point, I think we can finish the poll now, Gordana, and show the results so that everyone can get a clear picture of the poll. There we are. You'll be able to just scroll down through it, and you can see very quickly that we have a lot of agreement on that. If anybody particularly wants a copy of the answers, then just email us and we'll send that to you. But as you can see, it was really for your benefit as well as for ours. So thank you for your participation. Okay, so for those of you who are still with us, and my list say that most of you have stayed, thank you for that. Let's have some of the final questions. Here's one. Are there any tick bites that don't need antibiotic treatment? Who would like to take that?
I guess I'll be happy to do that. So, you know, when people get a tick bite, they've done studies in France. Ticks carry lots of different bacteria and viruses. There's tick-borne encephalitis. It's now actually in the UK. But the presumption is when you get a tick bite, Borrelia is the #1 bacteria that is the most transmissible. That's what we understand. So we don't have perfect diagnostics. We have to depend on our clinical, skills. So yes, there's tick-borne encephalitis now recognized in Devon, in the New Forest, and now in Norfolk. It's heading north. It'll be in Scotland soon, I imagine. But the point is if you get a tick bite and you get symptoms, you have to presume that Lyme disease is #1 pathogen, maybe other co-infections. So I would err on the side of treating, because there's no better testing we have available. You have to use your clinical judgment.
That's a helpful statement for you all to take away, isn't it? That this is a clinical decision-making situation. Here's another one. Is antibiotic resistance a problem? Professor Lambert, I think this is for you as well.
It doesn't seem to be. This is, interestingly, bacteria that rapidly replicate, mutate. Lyme is a slow-growing bacteria. It has a slow-growing cycle of almost a month. So we can't do resistance testing because we can't grow the bacteria, but it's thought that resistance is a very rare phenomenon with Lyme disease. So the standard antibiotics, doxycycline, amoxicillin, appear to work in the early infection. Unfortunately, in the chronic infections where it's longer standing, you may not see a response, as quickly to the antibiotics, but that doesn't imply resistance. So we don't think there's significant resistance for Lyme disease to the standard antibiotics.
Thank you for that. And of course, this is a good time to just remind everyone to come back for the next 2 webinars, because Dr. Lambert will be talking about treatment of the most difficult cases and the more complex cases and longer courses of antibiotics. So that will be the 22nd and the 29th of September. We'll do a similar session. What about this question? If a patient attends and does not think they removed all of the tick, would you give them antibiotics? Anne, what would you be thinking there?
I think this is something people worry about quite a lot. I think if the tick hasn't been fully removed, then by definition, it's been a traumatic event. So there is potential that if the tick was infected, that infection has been passed on, but it's just as likely that the tick wasn't infected. We said earlier the infection rate within ticks is 0 to 16%. So I think in terms of Lyme disease, you would just treat as any other situation. There's a potential risk, but you need to watch and see. Having said that, if you've left a bit of a foreign body in the skin, you might end up with a bacterial infection. So that would be something else to watch out for. Try and remove it if you could, see if there's any reason to treat a bacterial infection. One of the things I didn't say earlier was that if you feel it's still a toss-up between whether someone might have a cellulitis or it might be an EM rash, it's likely that doxycycline may be effective in treating a cellulitis. So if you're really not sure either way, it would probably be worth doing that. I don't know if anyone thinks differently, but I think people worry a lot about tick heads the head of the tick being left in, but it's not a Lyme risk as much as a potential local infection risk.
A few nods there. So top tip on the use of doxycycline there. Here's an interesting one. Should all patients with a diagnosis of chronic fatigue with a possible exposure to tick bite, even if no clear history, should they be treated with antibiotics? Dr. Lambert.
I'm happy to answer that question. So look, I get asked to see lots of patients with chronic fatigue syndrome. And I decline to see most of the patients who have had chronic fatigue syndrome from the day they were born. But you've got lots of people who are high functioning that all of a sudden get to be 42 years of age, and they all of a sudden get this acute illness that gives them chronic fatigue. And in that situation, you have to say, what precipitated that chronic fatigue? Chronic fatigue is not a diagnosis. It's a description of a set of symptoms. So, but what happens is they get put in the chronic fatigue basket. So I think and we now have COVID that's causing chronic fatigue, but they don't have chronic fatigue syndrome. They have COVID-induced chronic fatigue syndrome. So I think we should have, it's a red flag. If somebody has sudden onset of chronic fatigue syndrome and other multi-system conditions, because usually Lyme affects not just the brain, it affects other systems as well. So in the setting of somebody with chronic fatigue, sudden onset of chronic fatigue or recent onset who are previously well, I think you should have a low threshold for thinking Lyme disease, even in the setting of a negative antibody test. So the important thing is history, and onset of disease and multi-system manifestations. And that's as good as it gets. We don't have better diagnostics. The antibody test is not perfect. So I think you should have a low threshold. If you think Lyme disease is a possibility, and I do this, I tell my patients that I screen, I said, look, I think there's Lyme disease, and I'm going to put you in a trial to see if you respond. If you don't respond, then I stop the antibiotics. But the only reason I'm starting you in the first place is because I, as a clinician, think that your chronic fatigue syndrome may be explained by Lyme disease. It's until we have better diagnostics, that's as good as it gets.
And I would say within that, you are still within NICE guidelines. NICE guidelines says if you have a clinical suspicion, you can treat. And I've personally seen patients who've had chronic fatigue for a long time respond to doxycycline. Now, that may not, again, be a permanent thing, but if you've given a trial of treatment and you've seen an improvement, that patient can decide where they would like to go to from then. As a GP, you can't continue treatment, but you may have at least given them the opportunity to see whether there's any effect. But you're within NICE guidelines.
Thank you. And there's just been a follow-up from that same questioner asking, would that trial be 3 weeks of doxycycline then?
I would probably use 6 because a GP could only use doxycycline. I would probably use 6.
Right.
Dr. Lambert would have a different.
Yeah, well, the thing is that we, if you give, unfortunately, if it's chronic and it's been going on for a longer period of time, is the treatment for chronic infection the same as acute infection? Use Q fever, which is another infection. If you catch it early, 6 weeks of doxycycline cures early Q fever. But if you don't diagnose it to a year, you actually treat with a combination of doxycycline and hydroxychloroquine for 18 months. That is the treatment for chronic, late diagnosed Q fever. We have no guidelines for Lyme disease. So unfortunately, until there are guidelines, I think you should really use your clinical judgment. We use doxycycline for treatment of acne for 6, 12, 18 months, It's a safe drug to use. We shouldn't be using it just willy-nilly for everybody with chronic fatigue syndrome. But if you suspect an infection, I think maybe you should go longer than 3 weeks, but you have to kind of assess clinical response. And I cut people off. I stop treatment all the time when my hypothesis that there's an underlying infection is wrong. So I think we need to use clinical judgment. This is what medicine is about. There's a certain art in medicine. It's not just about guidelines.
Mm-hmm. I'm just thinking of people feeling protected within the system. It's a start. You could have a trial and without feeling you'd broken any rules.
These are helpful comments and coming from medics who are treating patients and seeing patients. So I hope that's been helpful to you, the questioners for that particular section. I've got sorry, someone.
There was a question I've seen from somebody that came directly to me, and I think it's I'd like to read it out if that's okay. It is from Eleanor. And it says, I saw in an outdoor store today, which is Trespass, Lyme testing kits for sale where ticks can be sent off for analysis post-removal. I don't know if anybody knows anything at all about that. I'm not aware of anybody selling kits. I know that ticks can be sent off. They won't be tested at Public Health England. You can send them there for their tick surveillance. They won't be tested there. But I think Rachel knows a bit more about tick testing in the UK.
Yeah, I know that the NICE guidance doesn't recommend doing it, but I think certainly that there can be a place for it. So in my little area where loads of people locally have had Lyme disease, if anybody gets a tick bite in my garden, I'd rather know. And of course, no test is 100%, so you'd never give it full credence. But for example, last summer we had 3 tick bites in the family. I sent 2 off, and they tested negative, and everybody was fine. The 3rd tick bite was me, and by the time I found it, I already had an erythema migrans, because I'd already had, I think my immunity was primed from my previous one, so I didn't need to send that one off. But that's about a 30% in that little tiny trial, 30% infection rate. I suspect it's about that locally. So I would always send them off from where I am. And there's a lab called BioBest up, I think, in the Borders that you can send it to. It's a vet lab, I think. So I've used them. And certainly a friend sent some ticks off that were attached to her small child. And of the 3, one of those came back positive. And we used that to argue for some prophylaxis, because it had been a traumatic removal. So there's not guidance, but where there's a really high risk and you don't just want to use prophylaxis blindly, I think it can be another tool in your armoury.
Thank you, Rachel, that's helpful. And I've just put in the chat box just now some information from the Lyme Resource Centre just on that, the links to BioBest and some of the other ones as well. So hopefully that will be helpful to you. A few of you have also asked about posters and awareness information. So again, there's information in the chat box for that as well. So that brings us to witching hour of 8:30. We've held you long enough, I would say. Thank you so much for joining us tonight, for staying with us, for giving us your really interesting questions. And please do come back for the next 2 parts of the seminar series, 22nd, 29th of September. This link will work for that as well. The recordings will be on the website, able for you to look at, and the evaluation form will come out to you, and Tina McHugh will organise for the Irish accreditation certificates too. So thank you to our speakers, thank you to you for joining us, and thank you very much. Good night for now.
Judy, bye.
Bye. Is that worth unmuting everybody?
Thanks for the great questions, everyone.
Yes.
See you in the next talks.
Thanks for everything, guys. Long day, so we'll reassemble. Okay, thanks for everything. Good night.
Thank you.
Thank you.
Thank you.
Yeah. Bye.
Gordana, I wondered if we could perhaps close off the participants.
Okay, so I will end the meeting. That will end everything now. And have a good evening, everyone.
Thank
Do you
you.
want to debrief or anything, or maybe another time?
Maybe another time, maybe we end the meeting for now.
Okay.
Let's end the
Thank
meeting.
you. Have a nice evening. Bye-bye.
Thank you very much, everyone. Good night.